We're going to talk about some of the disorders that increase the venothromboembolism risk. That is, the things that cause thrombophilia. Before we start, though, I want you to hear the punchline. You don't necessarily have to test for any of these disorders because the clinical scenario is going to determine venothromboembolism risk more than knowing their genetic disease. And if they have a genetic disease, you treat them as if they don't. You don't screen family members. You don't put them on lifelong anticoagulation until they have their second clot. And at that point, you'd be on lifelong anticoagulation anyway. But you should know the names of these disorders because they'll come up, and I'm going to use this as an opportunity to review the clotting cascade one more time. All right, let's start off with that cascade. We have the intrinsic pathway, which has some factors that you don't have to memorize. And you have the extrinsic pathway, which is exclusive and has 7. These two pathways come together at the common pathway via factor 10. Factor 10 is going to take factor 2 and activate it, a process that is mitigated by factor 5. Factor 2A, once activated, turns inactive factor 1 to factor 1A, activated, and it is from factor 1A we get clots. Factor 2 is better known as prothrombin, and 2A thrombin. Factor 1 is fibrinogen, and 1A is fibrin, thus the thing that forms the clots. The body's not stupid, so if all it did was form clots, we'd have clots everywhere. It breaks it down into D-dimers or split products via plasmin activated from plasminogen by TPA. The liver is responsible for making protein S, which activates protein C, which in turn inhibits factor 5. The liver also makes factors 2, 7, 9, and 10. Just got to know it. 2, 7, 9, and 10 are the factors the liver makes. So you could see already how there could be a number of targets that, if deranged, would increase the thrombotic risk. For example, if there were a genetic mutation that, say, prevented factor 5 from listening to the inhibition from protein C, that would cause increased clotting. That mutation is called factor 5 Leiden. Factor 5 Leiden is the most common, but the weakest in terms of potency of increasing thrombotic risk. The other one that we commonly encounter is a prothrombin mutation. Prothrombin 20210A, 20210A, just got to remember it. Prothrombin 20210A. These are both mutations, and if you're going to assess for them, you would look for the mutation itself. That is, you look for genetic markers that this is true. Some other diseases that exist are going to be protein S and protein C deficiencies. These are far more rare but more potent than factor 5 Leiden or prothrombin 2210A. Protein C and protein S being deficient would essentially be factor 5 Leiden. Factor 5 would allow to do whatever it wants uninhibited. In order to test for these, though, you have to check a level. And not up here is a thing called antithrombin. If you had an antithrombin deficiency, you would have increased clotting. This is also checked by a level. The problem is, and why I've highlighted them this way, is that during an acute clot, these laboratory values will be deranged. You can't check a level while having a clot. You can't check a level while on heparin. You can't check a level while on warfarin. So when would you test for this stuff? The answer is never. You could test for a factor V Leiden mutation or a prothrombin 2210A mutation, but chances are you're not going to do it. Just recognize that these things exist. But I also want to put into perspective for you how much these increase risk. Having trauma or having a surgery increases your venothromboembolism risk by 10-fold. Having cancer increases it by 20-fold. Factor V Leiden increases it by 1.5-fold. So the increased risk of having these diseases isn't as important as the clinical scenario. So if you have surgery or you're having some form of trauma, and over half the patients who don't get DVT prophylaxis and are admitted for trauma develop a DVT, you want to give this person prophylaxis. If the person has cancer and they get admitted to the hospital, they need prophylaxis. And prophylaxis is made with low molecular weight heparin. If they develop a clot, you treat it. And that requires a heparin to warfarin bridge. We discussed this in the DVT lecture. If you put someone on warfarin, you inhibit the production of protein S and C as well as 2, 7, 9, and 10. Now your goal is to inhibit 2, 7, 9, and 10 to raise the INR. But first you lose protein S and C, and so you induce a protein C and S deficiency by being started on warfarin, and if you don't put them on a heparin bridge, either low molecular weight or unfractionated, they're going to end up with a DVT. For cancer patients, though, cancer patients are treated very similarly. They're treated as a provoked DVT. They get a heparin to warfarin bridge. Unless they are metastatic, in which case they only get low molecular weight heparin, because chances are they're going to die of their cancer, not of their DVT. Last thing I want to talk about is antiphospholipid antibody syndrome, formerly known as APLA, now referred to as APS. Antiphospholipid antiphospholipid antibody syndrome. The pathology behind this is the lupus anticoagulant. Really annoyingly named. In vitro, it anticoagulates, but in vivo, it coagulates. So the lupus anticoagulant causes clots in the body. The patient is going to present with both arterial and venous clots. The diagnosis is going to be made by a Russell Viper venom assay, and the treatment is with warfarin. The goal is 2 to 3 on the INR. Failure means to simply increase the range that the INR goes for. So the only diagnosis in this entire lecture that matters, APLA. Diagnose that by someone who has lupus or someone who has multiple miscarriages and has both arterial and venous clots, and you put them on anticoagulation with a goal INR of 2 to 3. Interestingly enough, if they had a DVT, because they had a DVT, their goal would be an INR of 2 to 3. It says with APLA, if you make that diagnosis, they go on lifelong on their first clot. All these others would wait for the second clot, and then they'd be on lifelong anticoagulation anyway. That's thrombophilia.